Hello and welcome to the Endometriosis Care for Transgender Communities webinar. My name's Fleur. I'm the Community Engagement Officer at Endometriosis UK, and we're very lucky to be joined by two guest speakers today. So we've got Dr. Rich Flint and Jason Barker as well, and they'll be introducing themselves in just a moment. Before I hand over, I'd just like to remind viewers that this webinar is an hour long, and there will be a Q&A section at the end where Rich and Jason will be answering live and pre-submitted questions. But we ask that for any individualized medical guidance that you reach out to your healthcare providers. I'm also just going to do a quick content warning as well. So this webinar does include images of surgery and references to clinical terms that some could find triggering. Our webinars are all recorded and available online afterwards. So if you feel that you need to step away at any time, you're more than welcome to do so. Great. So I'll hand over to Jason now, who's just going to tell you a bit about himself.
Yeah, hello, I'm Jason Barker. I use he, him pronouns. I work for an organisation called Gendered Intelligence, and I've been working for GI, Gendered Intelligence, for about 12 years, first as a youth worker, and now I work on the training team, delivering training. And we as an organisation, I'll tell you more about us when it's my presentation, but we work with anyone who impacts on trans lives. And traditionally, when we started, we were very much focused on supporting young trans and non-binary people. But in recent times, we've expanded that and we've got more of an offer for older, for adults, and we're looking a lot towards older people as well and how we might support older trans and non-binary people.
Perfect. My name is Richard Flint. My pronouns are he, him. I'm just going to open my presentation. So yeah, as I said, my name is Richard Flint. I go by he, him. I am a consultant gynecologist and I work at Chelsea and Westminster Hospital. I've worked at Chelsea and Westminster Hospital since 2022, and I'm an open laparoscopic and most recently, and all my work now is robotic surgery. I'm also part of the Chelsea Endometriosis Centre, and I'm also one of two gynecologists who work for the Chelsea Centre for Gender Surgery. I wanted to thank Endometriosis UK and Fleur for inviting me to talk about endometriosis in transmasculine and non-binary patients. As Fleur had said, there are a couple of slides that might be dysphoria-inducing. I have tried to keep it as neutral as possible, so apologies in advance if anyone is affected by that. The aims of my presentation is to look at gender-affirming endometriosis treatment pathways and care, and tell you a little bit about Chelsea and Westminster Hospital, including what research we're doing helping transmasculine and non-binary patients. I'll talk a little bit about testosterone and estrogen and other gynecology and pelvic health issues. A little bit of background into the Chelsea Centre for Gender Surgery. So in 2022, we were commissioned by NHS England to provide masculinizing lower surgery for trans and non-binary patients who were assigned female at birth and had been diagnosed with gender dysphoria. Shortly after we set up the service, we recognised that there was a need for a separate clinic for transmasculine and non-binary patients to deal with any gynecological issues, not just masculinizing genital surgery. And so our specialised clinic was born. More recently, we have been now commissioned to do top surgery as well as feminizing surgery. When we sat down as a group, we kind of set out what our vision was going to be. And this kind of applies to all of the clinics that I do. And that is an innovative and patient-centered service based on the principles that patients must have equal access to surgical services, whatever their gender identity, with reasonable adjustments to the delivery of care to match individuals' needs and circumstances. These two handsome chaps, we are the Chelsea Centre for Gender Surgery gynecologists. You'll see Jeffrey Ahmed. He is a consultant gynecologist. He was previously our service director for the Chelsea Centre for Gender Surgery, and he is our lead for endometriosis and robotic surgery. He's also my mentor, and he is our gynecology service director. And then there's me, a consultant gynecologist, and currently the main clinical lead in the Chelsea Centre for Gender Surgery, and the main clinician who runs this separate clinic. I wanted to tell you a little bit about endometriosis in transmasculine non-binary patients. So we know that the incidence of endometriosis in the cis population is around about 10%. And in the trans population, actually, there's very little evidence, unfortunately. Anecdotally, of the patients that I take to theatre, mainly for hysterectomy for gender affirmation reasons, I've noted that at least 25% of those patients have had endometriosis as well. Some patients didn't know about it. Some patients have suspected it and told that they haven't had it. And so it has been affirming for them to know that they have. Neuro research actually does agree that 25% of diagnosed endometriosis in those undergoing gender affirming surgery. My concern is, however, I think the incidence is probably higher as many patients don't reach out for care. What I have noticed is that disease severity at surgery is often less than the cis population. So I see fewer endometriomas, but more peritoneal disease. And the likelihood is the effect of the patients, at least that I see, who are on testosterone in suppressing the endometriosis. It's important to note, however, that disease severity, in terms of what we find at surgery, doesn't correlate with symptoms. So you can have really significant disease and minor symptoms, and the opposite can be true. So very little endometriosis defined, but life-changing symptoms. We know that there are barriers to accessing healthcare and therefore receiving a diagnosis of endometriosis, which is why I think that the number is probably higher. And one of the other reasons is diagnostic overshadowing. Transactual did a piece of research looking at trans healthcare experiences, and they noted high rates of inequality and discrimination for trans patients when accessing healthcare. 70% were impacted by transphobia when accessing general health services. 14% were refused GP care. 57% avoided going to the doctor when being unwell. 45% felt their GP did not have a good understanding of their needs as a trans person, and 27% reported always or often avoiding seeking sex-related care, and this was worse with trans men. You can see why, with these stats, that actually I think that the incidence of endometriosis in our trans and non-binary population is higher because there are so many barriers to accessing healthcare. One of the things is the broken arm syndrome. So a trans patient will go in and see a clinician about their broken arm, but everything gets made to be about their trans identity. And so their broken arm gets completely overshadowed. And this is just one reason why patients don't get the care that they need. So this is endometriosis. This is what I see day in, day out with my patients. A couple of pictures here. So you'll see top left is bladder endometriosis. This patient had a lot of lower urinary tract symptoms that had been put down to their atrophy from the testosterone and hadn't even thought about having it being endometriosis. Here on the top right, you'll see a mixture of peritoneal endometriosis as well as rectovaginal endometriosis. And then similarly, the bottom two pictures of peritoneal endometriosis. I see a lot of peritoneal endometriosis, so that's when endometriosis lines the lining of the pelvis. I can often see it under the ovaries, which we currently don't know the link between orgasm pain and endometriosis. What I don't see very many of, which you won't see here or in this population, is endometrioma, which are chocolate cysts. That's when there's an endometriosis in the ovary, and then every time there is bleeding, then that fills more and more with altered blood. One thing I also do see a lot of is adenomyosis, which is the sister of endometriosis, and you can often get them hand in hand. And adenomyosis is when you get the lining of the womb in the muscle component of the womb. And so if someone is having cyclical bleeding, it can be more painful, it can be heavier, and it does sometimes pose challenges surgically. What is the current provision of care for endometriosis in the UK for trans and non-binary patients? Well, I'm sorry to say that there is unfortunately no NHS pathway specific for endometriosis in transmasculine and non-binary patients, with very few local pathways that I know of. I am in talks with a number of clinicians across the UK talking about helping each individual hospital set up special pathways to offer culturally competent care for patients, but they are few and far between. And so therefore the majority of patients will have to go through the same pathways as the cis population. This is an issue because patients don't try and access care. And if they do try and access care, sometimes they're not granted access to a hospital, which is what we call gatekeeping. To tell you a little bit about the clinic that I set up at Chelsea and Westminster Hospital. So when we set up our surgical service, not only were we receiving a lot of referrals for masculinizing lower surgery through the Gender Dysphoria National Surgical Service, or GDNRSS, but we then started receiving a lot of referrals for other patients wanting hysterectomy or other patients having gynecological issues. And so we recognized that a culturally competent clinic was needed. And so we set up a special clinic for our trans and non-binary patients suffering with pelvic problems, whether that be general gynecology issues, suspected or diagnosed endometriosis, and any pelvic floor dysfunction. All staff who care for our patients are part of the Chelsea Centre for Gender Surgery, or if they're not, they're given training by our patient champion so that they feel comfortable in providing that culturally competent care. The current treatment pathways, at least with us, is we will receive a referral from a GP to gynecology, and then my colleagues will know to triage that and direct it to our specialised clinic. We run a separate clinic, which is not within gynecology. It's in a completely separate area of the hospital, and it's a mixed waiting room. So there are all different types of people and how they identify in that room. We offer 45-minute appointments, and during those appointments, we'll go through someone's history, an examination if possible, which includes an ultrasound, and then we talk through medical and surgical management. All patients that I see, if needed, can be fed into our main endometriosis multidisciplinary team meeting, and they have the same access to our fertility services, and they're followed up by one of two clinicians, myself and Jeffrey Ahmed. What should you expect from a clinic appointment? Well, the first thing that someone will do is go through your history. So I will always check someone's pronouns, introduce myself, and then go through why someone is there. There'll be questions around pelvic pain, whether it's cyclical, whether you get pain with orgasm, pain outside of any cycle, or just general kind of pelvic health questions. I'll be asking whether symptoms, if you're on testosterone, started pre-testosterone. What symptoms do you get whilst taking testosterone, and did it improve since you started taking testosterone? Any bowel symptoms, so things like dyschezia, which is pain on opening your bowels, any blood in the stool, things like that. We'll also talk about bladder symptoms. So do you go for a wee a lot, more than is usual for someone? Does it hurt to empty your bladder? Do you get recurrent urinary tract infections? And then we talk about front hole symptoms. So do you use the front hole? And if you do use the front hole, do you get any pain with it? Is there atrophy symptoms? So front hole dryness? Is there bleeding with sex and things like that? If you are on testosterone, then we'll usually ask what previous preparations you've been on, and how long have you been on them. Some of my patients will also be on a blocker, so a GnRH agonist, which shuts off all of your hormones in your body, in which case then we give you the hormones back, and obviously the majority of my patients, that will be in the form of testosterone. If they are on contraception or any other hormonal methods, such as a progesterone-only pill, we'll talk about a smear history and then other medical and surgical history as well, including any chronic conditions and pain conditions. We know that certain terminology can be dysphoria inducing. And so what I would suggest is anytime you're going to see a clinician, feel empowered to send a letter to that doctor, outline any triggering terms. And then they can try and make small changes to what they do to make you feel more comfortable. When I see a patient in clinic, I'll try and use neutral diagrams of the pelvis to make things a bit easier. And then, as I say, there are simple changes that we can use to make patients feel more comfortable. So, I'll usually use the term front hole or cyclical bleeding, chest, things like that, just to try and be a bit more inclusive and try and reduce dysphoria. There are, however, limits on this, in that if we are writing to other medical professionals, which you might receive copies of the letter, or especially if I'm consenting for an operation, then it's quite important that we use the medical terminology so that there is no doubt in what we're doing. During an appointment, you'll have an examination. Patients are given time and they're supported through any internal examinations. And the main thing to know is that we have a very low threshold to abandon. So if anything is too painful or dysphoria inducing, we stop. Things that I found will help is the patient inserting a speculum themselves if we need to do a speculum, going slowly and reiterating that the patient is in control. And as I say, having a low threshold to stop, and we can perform the same examination either under sedation or a general anaesthetic on another day. I will scan every one of my patients. My first line of scanning will be an abdominal ultrasound, so jelly on the belly. But patients need to understand that this is not the gold standard to diagnose endometriosis. If there is a strong suspicion of endometriosis, or I cannot see what I need to on a transabdominal scan, then the patient will be offered an internal scan, and that can be either the front hole or the rectum, and that will be patient choice. If neither of those are acceptable, or the patient will find either of those two uncomfortable, then we stop, and then we will request an MRI. We'll also request an MRI if there is a suspicion of deep infiltrating endometriosis, so especially endometriosis between the womb and the back passage. What kind of things can we do in terms of treatment pathways when concentrating on a medical standpoint? Well, the aim of any medical treatment for endometriosis is to stop ovulation, stop cyclical bleeding, and suppress the endometriosis. So it really depends on whether a patient is on testosterone or not. If a patient's on testosterone, then it depends on what they're on. If they're on a gel, which is usually a short-acting testosterone that you need to use every day, then I would usually try to switch to an injectable. So Sustanon, which you take probably every 3 to 4 weeks, or Nebido, which usually is every 12 weeks, noting that everyone's window will be different depending on their T levels. If that doesn't work, then we can add in a hormone blocker. And then again, if not, then we can add in a progesterone type. So usually the progesterone only pill, we can double the dose. And then surgery is obviously always an option also. If a patient is not on testosterone, then are we able to start testosterone? So where are they in terms of their journey? What are their plans in terms of any bottom surgery? Have they been referred, or are they known to a gender identity clinic? And are they currently on a surgical pathway? If a patient doesn't want to go on to testosterone or can't start at that point in time, then the best thing to do is a progesterone. So that can either be a pill, Dynagest is probably the best, followed by desogestrel, or an implant which goes into the arm, or the Mirena coil, which sits inside the womb. My general advice would be avoiding the combined oral contraceptive pill, as this does contain estrogen, and so will have feminizing effects. When looking at surgical pathways, so the main thing to know about surgery is that surgery is not a cure for endometriosis. The main aim with surgery is to reduce the disease burden and try and improve symptoms, but it is not without risk. The other thing to consider is going to the right surgeon. So a lot of gynecologists will be able to do a laparoscopy, but not all gynecologists are taught to the level that is needed to spot subtle endometriosis or excision of difficult endometriosis. Surgery will depend on whether a patient has a diagnosis of gender dysphoria and what they want, basically. If a patient has a diagnosis of gender dysphoria and they're wanting bottom surgery, even if they're not, but they do have a diagnosis of gender dysphoria, then we will generally discuss a total hysterectomy, which is removal of the neck of the womb and the womb, as well as removal of the tubes, a lot of the time the ovaries and the endometriosis. And this can be all done at the same time, but surgery is dependent on the patient's symptoms and what they want to do. If a patient has, say, for example, if we get inside and there is significant bowel endometriosis, but the patient doesn't have any significant bowel symptoms, then often it is safer to not proceed with that. Once ovaries are removed, then there is minimal estrogen in the body, and so often we find that the endometriosis will stay dormant. Things to consider before surgery, however, is cryopreservation, so the storage of eggs, so that you can donate them to a partner with a uterus so that they can carry your pregnancy if you were thinking of removing your womb. At the Chelsea Centre for Gender Surgery, we have close links with our fertility team. Newer evidence that we have is actually showing that patients don't need to stop testosterone, and actually we get a pretty good result because of that. And we can usually get funding for patients, and that funding will pay for collection of the eggs and storage for up to 10 years. If a patient comes and doesn't have a gender dysphoria diagnosis, or they're wanting to keep their uterus, then what we would usually do is what's called a see and treat surgery. So we do keyhole surgery via the robot, and we excise any endometriosis that we find at the time. But again, it is really dependent on the patient's symptoms. If significant disease is expected because of symptoms or because the MRI has suggested so, then we'll usually again go through preoperative cryopreservation, especially in the case of endometrioma, when if fertility is still a want, then anytime we're operating on the ovaries, especially with the endometriomas, we will reduce, or there is the possibility to reduce the egg count in those ovaries. And so it all depends on what the fertility wishes are. Sometimes we will need to do two-stage surgeries, and sometimes we will need to do joint surgery with our colorectal colleagues. If all else fails, then definitive surgery with total hysterectomy, so removal of the neck of the womb, the tubes and the ovaries, as well as the endometriosis, is usually improves symptoms significantly. These are some pictures of some surgery. So on the left, you'll see we have some endometriosis that we're removing. This is just removing the peritoneum. In the middle, there is rectovaginal endometriosis. So again, we're removing that. And then similarly on the picture on the right, there's more endometriosis that we've removed on the right side wall of the pelvis. We do all of this robotically at Chelsea, though you can do this through the traditional straight stick laparoscopy to good results as well. Medicines and surgery are not the only way to manage endometriosis, and there is a wealth of complementary therapies that work. So there are a lot of diets out there, specific foods to avoid or to include, which will help with endometriosis. There is a massive overlap between IBS and endometriosis patients as well, and so looking at diet is one of the first things that should happen. I can't stress enough the importance of exercise, as well as stopping smoking and drinking less, or abstinence from alcohol will also improve conditions. Mindfulness is also good and can be used in conjunction with pelvic physio for pelvic pain. A lot of the problem that we see with patients with endometriosis and severe pain is that the result that it has on the pelvic floor. And what you'll find is the pain leads to what we call a high tone pelvic floor. And what will be needed is actually some relaxation treatment. My pelvic floor physiotherapy colleagues, especially at Chelsea, are well adapted to dealing with this kind of thing. There are a number of ways that it can be done using specific devices, internal examinations and things like that, but we'll come to that shortly. We're undertaking a lot of research at Chelsea, and every patient who we see is invited to take part in all endometriosis research if they are eligible, regardless of their gender identity. But what patients need to know is that a lot of the standardized questionnaires are unfortunately gendered, but we are working to revalidate these questionnaires for our trans and non-binary patients. Specific research into transmasculine non-binary group, we're currently a part of a multi-center study looking at the incidence and severity of endometriosis in this group. We have set up a pelvic floor muscle therapy acceptability research piece, which is basically looking at what do our patients find acceptable. So is internal examination from a physiotherapist acceptable? Are stim devices acceptable? And does that change with your gender identity, basically? So that's a questionnaire-based piece of work. We're also planning an observational study looking at orgasmic pain and outcomes post-hysterectomy with or without removing the ovaries and the association with any endometriosis. Estrogen and testosterone I spoke about a little already, but just to talk about again, I would avoid the combined oral contraceptive pill if you're worrying about feminizing effects, because the estrogen will have that. Local vaginal estrogens, however, are safe. They do not have any feminizing effects. They do not get absorbed into the body, and so will not have, as I say, any feminizing effects, or if you're on T, any reversal of the masculizing effects. When it comes to the testosterone, long-acting with endometriosis is going to be better. So that's going to be the sustanon on libido, and checking your levels are adequate, and then dose kind of interval may need to be narrowed or widened depending on your T levels. But that's going to be the best thing to stop any ovulation or bleeding, and stop any endometriosis from getting any worse, and hopefully make things a bit more manageable. The short-acting gels are less effective because they tend not to reach the levels in your blood that are required to stop bleeding, or ovulation, but they can be used in conjunctions with the progesterones that I spoke about earlier. One of the things I wanted to talk about was the importance of getting your smears, please. It's really, really important, but I know how either dysphoria-inducing or painful it can be for some patients. I know that our clinic in Dean Street in Soho, which is 56T, does run a smear service for our trans patients. But again, it's about making sure that the patient knows that they're in control. If there is a lot of pain associated with it because of atrophy, then local estrogens into the front hole can help before a smear. Or there is always the option to have a smear done under sedation or general anesthetic if patients find it too painful or dysphoria inducing. One thing that I talk about with a lot of my patients who are having bottom surgery is the importance of a normal smear, especially if they're undergoing a vaginectomy, which is a removal of the front hole. We need a normal smear to know that if there are any abnormal cells, they haven't spread to the lining of the front hole, and therefore the vaginectomy is safe to undertake. So if patients are wanting to have bottom surgery, I would please have your smear before. Other health issues, so I've spoken about atrophy already, but atrophy can be very painful. So when someone's on testosterone for quite a long time, then the lower, the front hole needs estrogen to a degree to do its job properly. So it can become dry, inflamed, it can bleed. And often that pain can sometimes give pelvic pain as well, and sometimes it can be confused. But, you know, treating atrophy is safe. Local estrogens are safe. And as I say, they don't have any feminizing effects, and they can help with a smear and if you're going on to have a hysterectomy later on down the line. Some of the other things I see patients for are sterilization. The thought of becoming pregnant is so dysphoria inducing for these patients, that being on a contraceptive alone isn't enough for them. And so we discuss sterilization, and my preferred method is with removal of the tubes, which is called a salpingectomy, over just clipping the tubes, because the benefit of removing the tubes is that there is also an associated risk reduction in ovarian cancer. Other things to think about is that if you're on T, it is not a contraceptive. So if you are using the front hole, please think about contraception and how you're going to protect yourself from unwanted pregnancy. If these are my take-home messages, so the first thing I want everyone to do is feel empowered. Don't settle, don't be fobbed off. There are people out there who want to treat you, know how to treat you competently, culturally competently. So yeah, please don't settle. Please come and see us. That's not just us at Chelsea, but please do approach your GP and get a referral for symptoms. Don't suffer in silence. And please seek a culturally competent clinician who can care for you. And I know a lot of my patients have a lot of reluctance engaging with research because they don't know how it's going to be used against the trans group. But please engage, because we are at least trying to help improve the lives of our trans patients. Thank you.
Wow, thank you, Rich. That was really informative and excellent. I know we've got a lot of questions coming in that we'll ask you just in a bit. I'm happy to hand over to Jason now to learn a bit more about gendered intelligence and how to navigate medical appointments.
Oh, thanks, Fleur. I'll just share my slides. That was so encouraging to hear from you, Rich. And I think that some of the things I'm going to say might double up with some of the things that you've said. But I'm going to talk more sort of broadly, more generally about navigating medical appointments. So first, about Gendered Intelligence. We were established in 2008. We're a registered charity, and our aim is to expand understandings of gender and improve trans lives. And we imagine a world where many different gender identities and expressions are visible and valued, and where trans, non-binary and gender questioning people live healthy, safe and fulfilled lives. And we're really we're very interested in this sort of the healthy life and what that looks like at the moment, and very interested in trans healthcare, obviously, and supporting trans and non-binary people. And we're a trans-led organisation. We're majority trans people working at Gendered Intelligence. So in putting this presentation together, I just wanted to point in the direction where I got a lot of the information was came from this organisation called outpatients.org.uk, who are an organisation who support LGBT plus people going through cancer diagnosis, and they've got some top tips on their website about navigating appointments, and I thought a lot of those were really useful and sort of applicable to any situation. So I was taking from there some ideas, things that you could do in advance of any appointment. Really is call the clinic to discuss how to make your appointment a better experience. I really liked Rich's suggestion about writing the letter in advance. I thought that was such a great suggestion as well. Let the clinic know the name and pronoun you'd like them to use. Ask to be seen at the beginning or the end of a clinic to avoid busy waiting rooms. And again, I just to sort of reiterate, I liked about in Rich's clinic how having a clinic that is a mixed waiting room. And I know that when I had to have a scan at my local hospital recently, I found them excellent in the way that they cared for me, in that the scan would normally be done on the gynae ward. They took me in round a different entrance. They'd sort of worked out a whole way that I could be in a different waiting room and then brought round to the scan through different doors. And I really appreciated, I suppose, them thinking that through as well. Can they call your appointment without putting your name on display? Just checking these kind of questions in advance. And can you take someone you trust with you? And that's often something people recommend. Can you take a partner or a friend or a trusted person? During medical appointments, and again, Rich was touching on language, I thought, in such a considered way, thinking about and talking about the language that you use for your body. And healthcare professionals should respect your choices when speaking personally. So when speaking to you about your body, they should be respecting your choices. And the but here is something I think that was interesting, talking about that maybe a clinician will need to write to you, to another clinician. That could be a time that there may be a time that clinical terms would have to be used. And they should be able to explain, any clinician should be able to explain in advance why and when they will use those clinical terms rather than the terms you've asked them to use, the personal terms. So thinking about somebody coming with you, coming to support you, and what you might need support with, and some ideas for that. Language, maybe if somebody is able to translate clinical terms to the language that you use for your body for you, or likewise to interpret for you back to the clinician if need be. Note taking, and it's always good having somebody else taking notes. Often in appointments, it's very difficult to hear information. Pronoun checking, and I mean, I write pronoun checking because it's a sort of a top tip that I like anyway. It can be very difficult, I think, to correct somebody when somebody's talking about us and using the pronouns we don't want them to use. And it can be really difficult. It can make you feel very powerless very quickly. And especially when you're in that sort of already that relationship, perhaps, of feeling vulnerable. So pronoun checking is a way that I use the idea of the pronoun check as a way of intercepting, I suppose. So for instance, if I was supporting somebody in an appointment and I could hear that perhaps the pronoun, the incorrect pronoun was being used, I could say, oh, can I just do a quick pronoun check? I believe Jason uses he. It's just a way of talking about pronouns. So somebody who can do that job for us. And I've put a note there that you don't owe it to anyone to be out. There isn't an obligation on any of us to be sort of out as trans or non-binary. If we're going to appointments and we're just getting through them the best that we can, for us, that's all right. So that I wouldn't want anyone to feel that there was a sort of pressure that we must represent in some way. We just sometimes need to get through things. So there's an organisation online, and actually they're also featured in Rich's slides, and they're called transactual.org.uk. And I think they're brilliant. And they've got a lot of really good good advice about trans healthcare, good information about trans healthcare and navigating trans healthcare. But also one of the things that I find that I thought was a really great resource is that they've got a resource. You can download it as a PDF, and it's called Nobody Teaches You How to Be a Patient, the lived experiences of neurodivergent, disabled and chronically ill trans people. It's brilliant. It's got real life stories and experiences written by trans and non-binary people. I thought it was excellent. And within that document, there are some top tips that they've given that I thought were great as well, and really sort of, I felt, summed up for any situation. Number one, you're an expert in your own lived experience. So just this being empowered to think, actually, we know our bodies. We know what feels right for us. We know when things don't feel so good for us. So just having that, I suppose, if we can believe that for ourselves, that our experience is in the middle of this, making a plan. And they were suggesting just writing things down, thinking about making a plan for perhaps what questions we need to ask for in appointments, not relying on other people to ask the questions that we might want them to ask, but instead having a plan of how we can get what we want or say what we want. Writing notes to bring to appointments. Consider bringing someone that you trust with you, as we've mentioned before. Ask for what you need. Keep records of your care, so keeping your own records as well. See if you can change what isn't working. So thinking about what's working for you, what isn't working, and perhaps then what could you change? Join online or in-person support groups, help that from charities, and doing our own research as well. But it's a really, I think, really good guide. I can't recommend it highly enough. So what GI offers, we do training and consultancy, and we work with anyone who needs us, really. We do lots of work with professionals who work with trans and non-binary people. We've got lots of resources on our website that we can provide to professionals or people can download. We offer free briefings, so we work with people on developing policies and glossaries, and we offer top tips and social media updates. But the things that I think might be important here is we've recently, in the last few years, we've been doing more services for 18+, and our support line is for anyone affected by current NHS trans healthcare waiting lists, and it's very popular but very well staffed, and there's more information about the support line, how to access it on our website. And a lot of people use our support line now to talk to another trans person. So the support line are a great resource, can offer signposting in all sorts of areas. And although their focus is on people on current NHS trans healthcare waiting lists, that is not hard and fast. And that sort of definition is very open as well, to include trans and non-binary people, maybe not yet on a waiting list or beginning to navigate healthcare. We offer youth work. We do groups for ages up to 25 as well. We can do mentoring with people as well, and one-to-ones. We've got residentials and trips. And we also offer support groups for parents and carers, and groups for families. We've got, as well as the support line, we've got another group, which is an online group that meet, who are called Waiting List Warriors, who again are doing sort of similar things, working with people in a sort of peer-to-peer support work, which is what we're moving to as well a lot. We've got a directory of therapists and counsellors. We do quite a lot of training. We do a regular 2-day training every month, training counsellors and therapists in working with trans and non-binary people. And we've built up a directory of people who've been through our training. So if anyone's looking for a therapist or counsellor who's been trained in working with trans and non-binary people, that could be a place to start. Thank you very much.
Thank you so much,
Do my
Jason.
share. Sorry about this, Fleur. There we go.
It's all good.
That's the one.
Right. Yeah, that was great. Thank you so much. Again, really informative, and some great tips in there as well. So we've had a lot of questions rolling in. So let's just get started. Just having a look. So there's a question here for Rich, and it says, do you accept patients from across the UK? I live up north and have previously seen a private gynecologist based in Scotland who says I'll be a good candidate for a hysterectomy.
Yeah, so you can ask your GP to refer you to anywhere. So a lot of my patients come across the UK, so Northern Ireland, Aberdeen. I see patients from all over. If you're coming from a long way away, then just let our admin team know, and then we can usually give you a later appointment, just to give you more time to get to the clinic and things like that. But we're very happy to see patients from across the UK.
Excellent, thank you. There's another question here that says, how would you go about finding a trans-friendly clinician? It feels impossible.
I mean, I feel you, in that I was looking when I was preparing this talk for kind of any resources out there, and there is nothing. So I was talking to Fleur earlier about possibly signposting, or producing something that we could put together that people that I know are friendly, and are culturally competent within this area. As I said, more and more people are reaching out to me for help, putting together standard operating procedures and how to care for their trans patients. So I think there is a will to do right out there, but I think we still have a long way to go. And I'm happy to put together, or try to put together, a resource that endometriosis could circulate.
Perfect, thank you. There was another question here saying, do you have any studies that demonstrate the feminizing effects of the combined pill?
So the combined pill has quite a bit of estrogen in it. So for patients who are on T, it is a lot of estrogen to be taking when we're trying to suppress the estrogen. I don't think there's any longitudinal studies looking at the specific outcomes of the combined oral contraceptive pill and what it does to a trans or non-binary patient on testosterone. But we do know that it is a significant amount of estrogen that I would avoid.
Okay, thank you. We also had a pre-submitted question as well, from somebody, and they said that basically they're non-binary transmasculine and they've been seeking HRT, like female to male. They've lost one ovary and may lose the other, so might need to go on HRT anyway, but would prefer to go on male hormones rather than female hormones. Is that something that they could access in the UK if they're not already on a waiting list for a gender clinic?
So that is difficult. So if a patient isn't known to a GIC, so a gender identity clinic, and have a diagnosis of gender dysphoria, then we are not able to prescribe gender affirming hormones to them. However, there are private providers out there who will give a gender dysphoria diagnosis and provide a prescription for gender affirming hormones, which then can be continued by their GP. Our service, the gender identity clinic that is attached to Chelsea and Westminster Hospital is Trans Plus, and they have a clinic 56T, which I alluded to, that do smears, but they also offer clinics once a week in the evening for trans patients who are not part of their GIC, and they will monitor levels. They will write letters to GPs to continue prescriptions for gender affirming hormones. So there are ways around it.
Excellent, thank you. So we've had a couple of questions about smear tests as well. So somebody's asked, will smear tests be accurate post-testosterone treatment?
So the testosterone can cause changes in the cervix. Of all of the patients that I have done smears on in my clinic, though, very few have come back as showing those changes, or at least if they have, they're interpreted by the doctors who look at the cells as such. So we're still able to tell whether something is abnormal, or whether it's just the testosterone changes. So it is still important to get, because we can tell the difference.
Excellent, thank you. And there was another question as well asking, what do you do if you have an abnormal smear?
So it really depends on the abnormality. And so when we take a smear, we're looking for abnormal cells. Well, nowadays, actually, what we're looking for is HPV. If a smear comes back as HPV positive, which is the human wart virus, of which a couple of strains can cause the change to the cells of the neck of the womb, which then can unfortunately progress to cancer. So if a patient's smears come back as high risk HPV positive, then we look at the cells that are taken, and then those cells are graded depending on what we find, and that will dictate what we do next, basically. Sometimes we can just leave it a year and then repeat the smear. Sometimes we will need to do treatment, whether that is burning away some of the cells or removing a piece of the neck of the womb. Worst case scenario, if there is a cancer there, then that's a totally different management, but that's a bit too much to go into.
Excellent, thank you. So we've had another question. What are the common long-term health issues you see in people who continue to take testosterone after an, sorry if I butcher this, an oophorectomy and complete hysto?
So things I discuss with my patients, so WPATH, which is our kind of overriding gender affirming surgery world organization, say that we shouldn't be removing ovaries in our patients just to reduce the risk of cancer alone, because we can do a good job just by removing the tubes. So when I talk to a patient about keeping or removing the ovaries, what patients need to know is that if they have their ovaries out, that they need to continue on T until the average age of the menopause for a cis woman in this country, which is 51. Otherwise, they will have no hormonal support. And so their bones become brittle, their increased risk of osteoporosis, which can cause the bones to break. Their heart can suffer, increased risk of heart attacks, and they will also have no sex drive, so no libido. Unfortunately, there is a lack of evidence about testosterone long-term in this group. And again, it is something that we're looking at. But what we do know is that heart disease in this group is probably higher than actually heart disease in the cis male population. But yeah, unfortunately, there's still a paucity or a lack of information on this. But the main things is I encourage or tell patients that if we've removed their ovaries, they have to continue T until 51. Now, a lot of my patients are concerned, what happens if they can't get hold of T? What happens if the NHS stops providing gender affirming hormones? The only option in that scenario would be to start a low dose of estrogen to keep you healthy.
Okay, excellent. Thank you. That was very informative. We've had another question. Can local estrogen for dryness for someone who no longer has ovaries trigger growth in endometriosis? They can't find any definitive studies.
No, it does not get absorbed into the body. So there's a lot of research within the cis population of blood levels of estrogen after taking local estrogens. There is a small peak in like the first hour and then nothing. And then there is nothing able to be detected, basically. So it is very, very safe as long as you are using the correct estrogens. So there are certain estrogens that we do not use in local estrogens anymore, which are equine, which come from horse wee, basically, but because they do cause a significant rise in estrogen levels in your blood. But otherwise, local estrogens are very safe and will not have a feminizing effect.
Excellent, thank you. So there's another question here. Does taking T kickstart the menopause?
So what you're doing when you're taking T is your brain goes, oh, I've got all of this testosterone around my body. I certainly don't need all of this estrogen as well. And so it will shut the ovaries off. And so technically that would be a medical menopause, but you don't get the symptoms because you're having all of the testosterone. So it's a lot of my patients who I see, especially for gender affirmation surgery, if they're coming and they're a little bit later on in life, so 60, 62, they haven't gone through the menopause because they will have, their ovaries won't be working anymore. as I say, average age of the menopause in this country for a cis woman is 51, but because they're on testosterone, they don't get those symptoms. Sometimes what you will need to do, is after we've done the surgery, you will need your T levels taken, because sometimes you will have to narrow the window and have your doses more frequently to prevent the symptoms. Because if your window is quite wide, and then all of a sudden we've done we've removed the pelvic organs, then sometimes those T levels aren't enough to keep those symptoms at bay, and so you need to just narrow the window for how often you have your T.
Okay, excellent. Thank you. So someone was wondering what your thoughts, Rich, are on the 2022 study regarding uterine tissue looking like prostate cancer under the microscope after more than 9 months of T, or more than or equal to 9 months of T.
So one of the other pieces of research that I'm doing at the moment, which I didn't write down because it didn't apply to endometriosis, is looking at, so I've done over 100 hysterectomies for trans guys. And so we have a wealth of data available to us on the tissue. And we're looking at my scan and how thick the lining of the womb is, and what the outcome of the tissue is that we've removed. And I've looked at all of it's called histology, which is the tissue, and not once has it been described by our histopathologist as looking like prostate tissue. That's all I can say, unfortunately.
Excellent, thank you very much. Okay, so we've got a couple more questions. Someone's asked, if you're already on a pathway with another hospital, can we request a consult or advice from this department? Coming up against resistance to a hysterectomy focused on fertility, which is not what I want, but I'm reluctant to start again because of massive wait times.
It depends on what you mean by a pathway. It depends on whether you're on a surgical pathway with GD and RSS and you're going on to have bottom surgery. Chelsea won't, at the moment, take those patients if you're halfway through an operation. But if you mean a pathway for endometriosis and you're under a different team, then we're happy to see you and give you a second opinion.
Excellent, thank you very much. Okay, and then I think we've got one more question that's been asked in. I've been refused 2 hysterectomies without ever getting an appointment. What should I do?
The problem with that is that a lot of hospitals see the referral, then they freak out, and they don't feel that they can culturally competently care for these patients. There is also a funding issue, which may become more of an issue, unfortunately, but we're looking into it. But if you meet criteria for a gender-affirming hysterectomy, or if you meet criteria for a hysterectomy that any cis woman would meet, then you should be able to have that. And as I said, we're happy to give second opinions. Your GP can refer to us and we can see you.
Excellent, thank you. I think that's all the questions that we've got in for now, in case anyone has got anything else they'd like to ask.
To ask Jason a question, actually, is that okay?
Yeah, of course, absolutely.
Jason, you offer support to patients who are on surgical wait list. Is that just for gender affirming surgery, or does that include endometriosis as well?
What it is it's funded by some of the clinics, so it's for people who are on gender identity wait lists for gender affirming, but no one's checking that. No one's sort of, no, we cannot talk to you. So our support line is very open as well. And it would be open to people to who want to talk to somebody about sort of other kind of waiting lists. I'm sure of that.
Because I know some endometriosis waiting lists are very, very long. And sitting on a waiting list in pain can often have a massive impact on someone's life. So yeah, it's good to know that the option is there.
Excellent. We've actually just had a couple more questions come through. So what can you do when you're refused GP care?
Is that GP care for, because again, there's some information on Transactual about things like bridging prescriptions and how to talk to your GP, or is it about endometriosis specifically, or just generally?
I'm not I'm not actually sure. They've just said GP care. Yeah.
You can, if a doctor, part of the GMC guidance of good clinical care is that a doctor cannot refuse care based on their opinions of your life. So whether that is your gender identity, your race, your religion, your sexual orientation, if they do not feel comfortable caring for you, and there is for whatever reason, they have an obligation to find someone who will care for you. But they shouldn't be able to decline care based on your gender identity.
Excellent, thank you. And then one last question. If a medical professional was interested in being more culturally competent, how can they sign up with your program? I think that was directed to you, Rich. Or how can...
Oh, sorry, I thought it was because I noted from Jason's talk that gender, his organization provides teaching and training for that specific thing. So gendered intelligence sounds like it was a great in to that.
Oh, sorry, yeah, that was probably Jason then.
Yeah, I mean, we do lots of training with different NHS trusts, lots of open trainings that people come along to for exactly that purpose. So and we're always open to sort of people wanting to recommend our training, or so yeah, we can definitely do that.
Excellent, thank you. We've just had a couple more questions come through on the back of that as well. Someone said, my private clinic has prescribed a blocker and my GP is refusing to give it to me. What should I do?
So in that's, it depends on why your GP is doing that. But if it's been recommended by a private clinic, then sometimes GPs won't prescribe things if it's so it has to be on their formulary, which means they're allowed to prescribe it within their area, basically. If they can't prescribe it because of local policy, then sometimes there are alternatives that they may be able to prescribe, or sometimes you will have to seek a private prescription, but knowing that the cost of the medication probably will be higher. Going back to 56T in Soho, they do provide support for this kind of thing and can write to GPs on your behalf and try and encourage them to do that.
Excellent, thank you. I think the follow-up to that is they've asked, is it through a shared care agreement?
Yes.
Okay, perfect, thank you. And then another question is, did you say that the incidence of endometrioma in trans people is very low?
So I'm saying anecdotally, so from my experience of over 100 patients that I've operated on, I've seen very few endometriomas, but I caveated that with that is my experience. A lot of my patients have been on T from a young age. And so you tend, obviously with the T, you get suppression. And so things don't get as advanced, but that is not definitive. That's just my experience. More research is needed into the severity of endometriosis, which is part of the study that we're looking at to see the severity and the incidence, so that I can then quote you an exact amount rather than just saying from my experience.
Excellent, thank you very much. Okay, I mean 8 o'clock is rapidly approaching. I think there's got time for maybe one more question. Okay, someone's asked, for those with endometriosis in our community who have been refused hystos on the grounds of age and fertility reasons when they've already tried many different fertility treatments, would requesting a referral to you be a good idea?
I mean, we're happy to see patients. Sometimes you will get the same answer from us, but we try and be as inclusive as possible and not gatekeeping. So we're very happy to see patients and talk to patients and try and provide the care that you need.
Excellent, thank you very much. Okay, in terms of questions, I mean, it's 8 o'clock, so I think we've kind of run out of time in that respect. If anyone does have any more questions that, they've got a burning questions, you're more than welcome to email us at inclusion@endometriosis-uk.org, and we'll follow up with those for you. I just wanted to thank Rich and Jason for coming along today, and for everyone who's attended this webinar on endometriosis care for transgender communities. There is a survey at the end of this webinar, so once you close the webinar, it will pop up, and that's for feedback, so that we can take on board, obviously, your feedback for future webinars. And we ask that if you have the time, please do fill that out. And yeah, and thank you so much, Rich and Jason.
Thank you.